Okay, good afternoon. Thank you for joining this webinar that is jointly organized by the ERN EURO-NMD, Rare Neuromuscular Diseases, and the working group Peripheral Neuropathies. Today, we're very happy to have Professor Peter van den Bergh present a webinar on the electrodiagnostic patterns in immune-mediated neuropathies. This is a webinar within our series about immune-mediated neuropathies that has been going on since January. And it is obviously a very important topic that we have in our daily practice. Professor Peter van den Bergh is a full professor emeritus at the University of Leuven in Belgium. He is a neuromuscular expert and trained with the ALS Foundation in the USA and also at USC in Los Angeles and Tufts New England Medical Center. And he's board certified by the American Board of Electrodiagnostic Medicine. He has established the neurosciences, the Neuromuscular Reference Center at the University Hospital St. Luke in 1999 and received the Center of Excellence label from the GPS CIDP Foundation International. He's an executive board member of the European Reference Network EURO-NMD and co-chair of the EURO-NMD Neurophysiology Group. His main research areas are inflammatory neuropathies, electrodiagnosis, and functional assessment scales in neuromuscular patients. Professor van den Bergh has published more than 211 peer-reviewed publications with a very high age index, and he has been the past chair of the Inflammatory Neuropathy Consortium of the Peripheral Nerve Society, and he has held leadership positions in the Belgian Neurological Society, the Belgian-Dutch Neuromuscular Study Group, the World Muscle Society, the European Academy of Neurology. He's a fellow of the EAN and also of the American Academy of Neurology. Again, Professor van den Bergh, thank you for joining us today, and we look forward to your presentation. And after the talk, we will have some time for questions and answers from the audience. Thank you.
Good afternoon, ladies and gentlemen, dear colleagues, and thank you very much, Cleopas, for your nice introduction. So we will talk about electrodiagnosis in immune-mediated neuropathies. I will start with the principles of electrodiagnosis, then try to go through the main immune-mediated neuropathies. So this is the setup for nerve stimulation and recording of the action potentials. And this is a simplified motor nerve with two motor units. And each axon is innervating two muscle fibers. Now, if we stimulate the motor nerve, then what we get is two motor unit potentials in red. And these summate to give the compound muscle action potential, or CMAP. If one axon is degenerating, one motor unit potential will disappear, and what we will see is a decrease of the amplitude of the CMAP, and this wherever you stimulate distally or proximally. So conduction velocity is normal, but if you lose fast conducting axons, there might be some slowing of the conduction velocity. This cartoon shows the production of nerve action potentials. They jump from one node of Ranvier to the other. And for this to happen, you need enough driving current. It should be larger than the threshold for depolarization. And this is the case here. Now, in case of demyelination, what happens is that there is dissipation of the current, and you will not have enough current to depolarize the node. And then you get slowing of conduction and conduction block. Temporal dispersion is a normal phenomenon because not all axons are going to work at the same speed, to conduct at the same speed. If there is demyelination, patchy demyelination here, then what will happen is that you have a normal CMAP distally, but if you stimulate more proximally, the motor unit potentials will not travel together anymore, but after each other, and they are smaller and wider. And this is a nice example of such a dispersed potential. Then conduction block is the failure of axon potential propagation to the given side of a normal axon. And if sufficient axons are blocked, then you get a proximal to distal CMAP decrement, as you can see here. So the consequence of demyelination at the level of the axon are reduced conduction velocity and conduction block at the level of the nerve. Same thing, but you will also have increased temporal dispersion. Let's move to CIDP. This is the task force of the CIDP guideline, which dates from 2021. There is typical CIDP and there are variants. Typical CIDP is the most common disorder. And here you can see how this looks like. No. Okay, there we go. So there is weakness in the forelimbs, and here you can see how the patient has trouble proximally in distal and distally in the lower limbs. So it needs to be proximal and distal. Now, in distal CIDP, it's exactly the same as typical CIDP, but there is no proximal involvement. Then we have multifocal and focal CIDP. There is weakness in at least two limbs. It is multifocal, different peripheral nerves affected, and it's mainly there in the upper limbs. If it's only one limb that's weak, then it's focal CIDP. For motor CIDP, there is weakness in the forelimbs and sensation is normal. Then for sensory CIDP, there is normal strength and there is sensory loss in forelimbs. Now let's look at the criteria. There are a number of motor conduction parameters. Conduction slowing should be at least 30%. Distal latency prolongation should be at least 50%, and F-wave latency prolongation more than at least 20%. Then we have conduction block, which should be a decrease in amplitude of at least 30%, and temporal dispersion, a duration increase of at least 30%. Then there is another parameter, which is distal CMAP duration prolongation. You can see it on the right here. So what happens is that here you see the normal duration, what we take as the duration, which is that of the first negative peak. But for this parameter, it's really much wider. It's until the last negative peak that crosses the baseline. And then we have also now the criterion of sensory conduction abnormality in two nerves. So if one conduction parameter out of 6 is abnormal in two nerves, the criteria are fulfilled, I want to say, then this is strongly supportive of demyelination. If it's only in one nerve, then it's only compatible with possible CIDP. And here, clinical criteria, of course, have to be fulfilled. So what you can do is indeed, if the diagnosis is possible CIDP, you can make it CIDP if the patient fulfills 2 supportive criteria: CSF, imaging, response to treatment, or nerve biopsy. And it's interesting to see that if you compare the criteria of 2010 with those from 2021, this is a rather large study that tried to validate the criteria, then you see that there is some loss of sensitivity as compared to what we had in 2010, but the specificity is very high. So as we already saw, if criteria are fulfilled in 2 nerves, you can make a diagnosis of typical CIDP. If it's only in 1 nerve, possible typical CIDP. Now, what we did is to make it possible to have at least a diagnosis of possible typical CIDP if the electrodiagnostic criteria are not fulfilled. And that's the elements are objective improvement following treatment and at least one additional supportive criteria. For distal CIDP, motor conduction criteria should be fulfilled in upper limb nerves, not in lower limb nerves. For possible distal CIDP, it is abnormalities criteria fulfilled in one upper limb nerve or motor conduction criteria fulfilled in two lower limb nerves. Then we have the multifocal and focal CIDP. Motor conduction criteria need to be fulfilled in two nerves in total in more than one limb. And for focal CIDP, it's in one limb. Possible multifocal and focal CIDP, motor criteria are to be fulfilled in one nerve in one limb. Motor CIDP, sensory conduction is normal in 4 nerves and motor conduction criteria in 2. If it's in only one nerve, it's possible motor CIDP. Now, in most patients with clinically motor CIDP, there are sensory conduction abnormalities. And in that case, we call this motor predominant CIDP. And now finally, for sensory CIDP, there are specific sensory conduction criteria, and these are sural sparing pattern. As you can see here, this is the median sensory nerve, and you see that there is an absent response, inexcitable sural nerve, median nerve, sensory action potential, and the sural nerve is completely normal. And then there is also conduction slowing. That's the second possible criterion of more than 20%. Of course, motor conduction needs to be normal in 4 nerves, and it's a maximum diagnostic certainty of possible sensory CIDP. Now, here also, it is quite frequent that in these patients with clinically sensory CIDP, that motor nerve conduction abnormalities are present. And if these fulfill the motor conduction criteria in 2 nerves, then we can call it sensory predominant CIDP. In only 1 nerve, then it's possible sensory predominant CIDP. Now, there is a condition that's called a chronic sensory, that's called chronic sensory polyradiculoneuropathy, CISP. And this was described for the first time in 2004, but now the series has been larger. So an additional 13 patients have been studied. And the interesting thing is that these patients with clinically gait ataxia and sensory loss, that the nerve conduction studies are completely normal, motor and sensory, but there are abnormal some of the sensory evoked potentials. There is increased spinal fluid protein. There are MRI abnormalities, and interestingly, these patients respond also to IVIG or to corticosteroids. In 3 of these patients, a dorsal rootlet biopsy has been done, and it gives some evidence. It gives evidence for an inflammatory lesion. Clearly, what is involved selectively are the sensory nerve roots proximal to the dorsal root ganglion. We don't call it CIDP because of the normal sensory motor nerve conduction studies, which means that it's not really a neuropathy, but a radiculopathy. Okay, we can move to autoimmune nodopathies. Patients who have this condition do fulfill clinical and electrophysiological criteria for CIDP. Often these patients have distal involvement, but proximal involvement can also occur. The features of these nodopathies are quite special. can have, you often have, is Guillain-Barré like onset, very acute, subacute. There can be tremor and ataxia, there can be respiratory failure or cranial nerve involvement, nephrotic syndrome, very high CSF protein levels, and resistance to treatment, in particular IVIG. And these patients do have antibodies against cell adhesion molecules at the node and at the paranode. So here you can see that these proteins, contactin 1, neurofacin 155, Casper1, and the neurofacin isoforms and gliomedin, that these secure the axoglial junction at the paranode. And for NF neurofacin 186 or 140, it's they bind to gliomedin. And so the connection between the myelin lamellae terminal loops and the axolemma is secured. Interestingly, most of these patients do have IgG4 antibodies, which are quite particular because they don't cross-link. They do not activate complement. They have low affinity for the Fc gamma receptor. And here you can see that under normal conditions, that there are there are problems with though in the normal person there are the transverse bands that tightly attach the myelin loops to the axolemma. And if you have antibodies against one of the cell adhesion molecules, then these transverse bands disappear. On electrophysiological level, what happens in patients who have these antibodies is that the node widens because of the detachment of the terminal myelin loops, and this leads to increased current leakage across the terminal myelin loops, which means that because of dissipation of the current, that you have problems with the transmission of the action potential. You get first slowing and then conduction block. Merely absence of inflammation and demyelination. We call these, we do not call this CIDP, and we take the terminology of autoimmune nodopathies is the correct denomination. It's very important to recognize these patients because let's move to Guillain-Barré syndrome. The guideline was published in 2023, and here is the task force. Guillain-Barré syndrome, you have different forms, you have different variants, and classical GPS is sensory motor and the pure motor, and reaches its nadir in 2 weeks. So I'm going to concentrate on the classical GPS. So why would we need nerve conduction studies in GBS? Well, it is important to support the early diagnosis. It's important also to try to make a differential diagnosis of disorders which may mimic GBS. A third point is that subtype classification into demyelinating and axonal GBS is not helpful and currently has no bearing on management and treatment. I don't want to say that it's not important, but so far there have been no good results to try to differentiate clearly CIDP from the axonal GBS group. So what you need as you can see, this is a table that comes from the Brighton case definitions for GBS, and you see all the parameters that you need to make a level of diagnostic certainty, and the highest level is 1. As you can see here, nerve conduction studies consistent with GBS are crucial to have the highest level of diagnostic certainty. And this means that the nerve conduction study patterns need to be consistent with polyneuropathy, as described for GBS. And I refer here to Haddon et al. In 1998. So it should be axonal or demyelinating, inexcitable, equivocal. So any abnormality is good to say that it is consistent with GBS. Abnormalities of nerve conduction parameters are frequent, as you can see, and the highest level, the highest number percentage is found for the H reflexes, but then there's conduction velocity, distal latency, CMAP amplitude, F waves, and so on. For differential diagnosis, that is the differential diagnosis is huge, and of course I'm not going to treat this in detail. If there is an abnormality of the central nervous system, then the nerve conduction studies will be normal, and the only abnormality is really decreased activation, which orients toward a disorder of the central nervous system. For neuromuscular junction disorders, there is evidence of neuromuscular junction failure. And one of the things you see is abnormalities of repetitive stimulation. Here that's normal. Here you see that there is a decrement. This is a single fiber. Very sorry, I'm taking that. Very sorry. So as you can see, a single fiber recording shows you an abnormal jitter. So there is a first action potential, and then it's a muscle, from muscle fiber. And here is the second one. You record these, a series of about 100, and then you'll see that there is an increased jitter. And sometimes, as you can see here, there is a disappearance of the second action potential, which is neuromuscular blocking. Now, for muscle disorders, for myopathies, what we can see are excitability changes and also an abnormal potential pattern. So there is early recruitment, which means that you get a full that we get a lot of potentials for not too much effort. And you see that these potentials are called, brief small amplitude potentials, which you see with early recruitment. So the patient doesn't do that much, and you see a recording of many potentials. Now, what are the possibilities? You have abnormalities that have a high sensitivity but a low specificity. First of all, you can have sensory or motor conduction abnormalities that are consistent with the polyneuropathy, which are quite basic. Interesting is that absent H reflexes are very frequent in GBS. So you stimulate at the popliteal fossa, you record from the calf muscles. And if the H reflexes are absent, are present, then this is an indication that it may not be Guillain-Barré syndrome. And then there are abnormal blink responses. This cartoon shows what this means. So you stimulate the supraorbital nerve, sensory nerve, and you record from a facial muscle, by the facial nerve. And then what you see is that you have an R1 component, which is ipsilateral, and you have an R2 response on both sides, ipsilaterally and contralaterally. So this is an example of a normal blink reflex recording. You'll clearly see the R1 and the two R2s on the right here and there on the left. In patients with GBS, what you can see is this. So it's a disappearance of these two responses, R1 and R2. Now, what has higher specificity but low to moderate sensitivity is the soil sparing pattern. I spoke about this at the beginning. What's also rather frequent are indirect discharges. If you really look for these, you see them in many patients with Guillain-Barré syndrome. So as you can see, this is a result published by Roth and Magistris a long time ago. So this was very well documented, and it's clear that these indirect discharges are multiple. Here you see at least 3 of them, and in this example you see many more. It resembles to some extent A waves, which are axonal reflexes, but they are different. And it is also distinct from F waves. So this, if you see this, then indeed this is relatively typical for Guillain-Barré syndrome. And then there is also the distal CMAP duration prolongation. In this patient, you see that the duration of the potential is 13.6 milliseconds, whereas in normal conditions, it should be less than 8.8. So that's more than a 50% increase. And then let's move to the last section, and that's multifocal motor neuropathy. So this information comes from the 2010 multifocal motor neuropathy guideline. I'm going to talk about it, even knowing that for the moment, revision of the guideline is starting. Core clinical criteria are chronic or stepwise progressive focal limb weakness, usually almost always in a peripheral nerve distribution, and there should be at least 2 nerves involved. There is distal predominance, and it's usually in the upper limbs. It's asymmetric. Progression should be at least over 1 month, and usually it's more than 6 months, and there should not be any sensory sign or symptom. The supportive criteria are decreased or absent tender reflexes in affected limbs, cramps and fasciculations, no cranial nerve involvement, and improvement with treatment with IVIG. Supportive criteria include antibodies against IgM GM1, increased TSF protein, abnormal MRI and objective clinical improvement after IVIG. Now we know that ultrasound is also is very important. It gives more detailed information. You see the radial nerve of the right arm, which is much larger than in the left arm. The electrodiagnostic criteria are relatively simple. There should be motor conduction block in at least one nerve. A diagnosis of definite MMN can be made if the CMAP area decrement, not just the amplitude of the area, which means the surface under the negative peak. It should be at least 50%, and duration prolongation should be less or equal to 30% maximum. For probable MMN, the CMAP decrement should be at least 30% with duration prolongation of less than 30%. And the other possibility is that the decrement is at least 50% with duration prolongation of less than maximum 30%. This is an example of the radial nerve. As you can see, this is a recording from two radial nerve innervated muscles, proximal and distal, and more distal. And then you'll see that there is a large reduction of the area under the negative peak, which makes that it is a very important conduction block. In contrast, sensory nerve conduction is normal. Now, about the pathophysiology, it has been taught at the beginning for a long time that it is demyelinating neuropathy. But now the question arises, is that really true? And there is more and more evidence that it might be a nodopathy. And this is because of the findings that there is the disruption of calcium homeostasis with an increase in intercellular calcium. And that, of course, is something that can lead to neuronal injury by activation of caspases. On the other hand, there is also the classical complement pathway that gets activated, and where you get formation of the membrane attack complex, which means that there's also influx of calcium with neuronal injury as a consequence. And that this is an overview of what I was talking about. We now have the rather large group of patients with CIDP in the variants. We have Guillain-Barré syndrome and an overlap with acute onset CIDP. We have the autoimmune nodopathies. We have the monoclonal gammopathies with, amongst others, anti-MAC neuropathy, which I didn't talk about. There is CISP, which is a sensory neuropathy, and we have MMN. This is about what I wanted to say. Thank you.
Thank you very much, Professor van den Bergh. This was a very thorough and comprehensive review of all the electrodiagnosis of autoimmune neuropathies. We have some questions from the audience. And the first one is by Jintaudes Musait. I hope I pronounced correctly. In your experience, does ERB's point stimulation add much diagnostic value in immune-mediated neuropathies? So that was the question.
Yes, it might. The problem with this kind of stimulation very proximally is that it is not always possible to get supramaximal stimulation, that you that you may get a misdiagnosis because you cannot really reach all the nerve fibers. And so you will make false diagnosis because you will think that this conduction block, and in reality it is not. So that's the drawback. But if in many cases you can try to do it, and often indeed you can be relatively certain, but it still is tricky.
So you would not recommend it in the routine electrodiagnosis of, autoimmune neuropathies?
I've done it frequently. It depends also on the patient. If it's a patient who is really obese, it may be more difficult. So it's much easier to be certain if you stimulate at more distal sites. But this doesn't mean that you cannot try it. So it's worth trying.
Yeah.
But you should keep in mind that you may misdiagnose the patient with this stimulation of the brachial plexus.
Great. The other question is by the same colleague. Is snap duration of diagnostic value?
Snap duration?
Yes.
Nobody has done studies, I think, about this. But it's different from a motor nerve because it's a very tiny potential, and it's very difficult to find out whether it is really temporal dispersion. If there is decreased amplitude, of course, that's important also. So it can be useful. So if you want to know whether there is sensory involvement or not, then the sensory nerve action potential of the sural nerve is important. For example, the sural sparing pattern, where in a neuropathy where you have a normal sural nerve response, and in the medial or the ulnar nerve in the upper limb it's absent, then of course it's very informative. Then you know that it is probably a disorder that's compatible with a demyelinating disorder.
Okay. So thank you. There is another question about the GPS-related nodopathy by Satika Özdemir. They write, in GPS-related nodopathy, we observe that conduction blocks resolve quickly. Do we see the same in nodopathy associated with CIDP?
Well, the difference with CIDP is that at GBS, everything can change quite rapidly. So, yeah, it's certainly possible, but it's not easy to interpret, because it depends on the stage of the disease. It depends also on the nerves that you examine. So in my experience, it's something that can change quickly, and then that's one of the reasons why it is thought that doing serial studies is important, and I agree. And then what we have done a study on this also, and you see that if you do a stimulation at the entry, the patient comes into the hospital with GBS, and you compare the results with something with nerve conduction studies 3 weeks later, then you can see that it can move in different directions.
But okay, thank you. But I think in terms of the nodopathy variants, the chronic variants, you would expect to see a faster resolution of the abnormality just because of the pathophysiology. The constitution of the nodal architecture will be faster than, restoring myelination over an area of demyelination in the typical CIDP.
Yeah, that's indeed the problem of acute onset CIDP. If the patient comes in, it really looks like GBS, and you need time to know that it is not. And according to the criteria, the clinical criteria, that you need that GBS is not GBS if it continues to deteriorate 4 weeks after onset of the disease. Yeah, it's almost clear that you cannot make the diagnosis early on.
Yeah, great. Thank you. So, and I guess this will mean that you treat initially as GBS and unless proven otherwise later. Yeah,
that's right. And I've seen many patients with this syndrome, with acute onset CIDP, who do at first maybe respond a little bit to IVIG treatment, which is often the first treatment that's given in GBS patients. And then they continue to deteriorate. And then when you treat them with corticosteroids, then you see that it works. And these are patients that's typical for acute onset GBS. That's one of the things that you find out. But often after a delay of many weeks.
So would you plan routinely a repeat electrodiagnostic evaluation just to make sure that your initial demyelination findings are improving?
Yes, because often if it's really GBS, you have abnormalities, nerve conduction abnormalities that are suggestive of demyelination. But then again, if it's a nodopathy, this is can also be of an axonal origin, as I have explained for several disorders, in particular the nodopathies. So that's certainly true.
Great, thank you. There is one more question. Can a nodopathy be suspected only on the basis of a single nerve conduction study?
Just at one point in time, or?
I assume that's what Viviana, who posted the answer, means. Just one time electrodiagnostic study.
Well, I think it's not going to change that much. So if you find this initially, a few weeks after onset, for instance, it will give you the same kind of result weeks later or even months later. It may be worse, that's true, but it will always be slow conduction and conduction block, which is difficult because you cannot differentiate nodopathies from clearly demyelinating neuropathy like CIDP. It gives you the same kind of electrophysiological abnormalities.
But would you consider that the lack of temporal dispersion with a drop in CMAP will be more suggestive of a nodopathy as opposed to typical CIDP?
Difficult to say, but it's clear that you can have conduction blocks, and it's true that temporal dispersion is maybe less common in nodopathies, but there also it's very difficult to be certain.
Okay, yeah, that's very useful. So there is a follow-up question. Do you recommend performing mixed sensory nerve studies to differentiate between multifocal motor neuropathy and MATSAM?
Multifocal neuropathy is the same as MATSAM, so it's Lewis-Sumner syndrome.
Yes.
And the question, what was the question again exactly?
If you recommend performing mixed sensory nerve studies to differentiate between multifocal motor and MATSAM.
Oh yeah, now I understand. So it's MMN or MATSAM.
Yes, yes.
Well, the main difference is the sensory nerve conduction studies. So in multifocal CIDP, you need sensory abnormalities to make the diagnosis. And in multifocal motor neuropathy, these are not there.
Okay.
After a long progression and a long duration disease, then there might be some sensory involvement, but when you try to make a diagnosis at the beginning, in the first few months, or even maybe longer than just a few months, then you should not see sensory abnormalities, because then that's a differential diagnosis with MedSam, with Lewis-Sumner syndrome, with multifocal CIDP.
Yeah, obviously this would be the main difference, that you have no sensory involvement in MMN as opposed to
that's right. Yeah.
There is another question, how to differentiate motor CIDP versus MMN. Maybe that relates a little bit to my question before. So electrodiagnostically.
Yeah, it's the clinical phenotype that's different. So multifocal motor neuropathy is, as the term says, it's multifocal. Usually limbs only, but that of course you can see with ALS. But that's not the case with motor CIDP, because there is proximal and distal involvement, and it's quite symmetric, and it's the four limbs. So that's quite different from multifocal motor neuropathy.
Okay. Let me see if we have any. There is another question from Eva Vikova. How long do the demyelinating changes last in people who have GBS?
They can be permanent. But if there is a lot of axonal involvement, of course, if the patient recovers, then over the years, it may improve.
I think maybe if the way I understand it is, how long would you expect that the demyelination criteria are no longer met when you follow up a GBS patient, at which point you say, the demyelination is not active anymore, so I'm not worried about, CIDP developing as opposed to GBS monophasic demyelinating event.
Well, I'm not sure that there are many data available for this, because GBS patients, okay, it's very important to make a diagnosis, and sometimes you may do a follow-up study after weeks or months, but in the long term, I don't think there is anything clearly known about the question, about the answer to the question you're asking me.
Okay. I had one more question about the MMN. So in terms of the GM1 antibodies, how do you consider the frequency with which they are detected in MMN patients? And what is the specificity? Can you have, low titers that are not really specific for MMN? Or,
Yes, certainly. Yes, the titers are of some importance. And these antibodies are not present in every patient. So if you look through the series that have been published, it's somewhere between 40 and 50%. So at least half of the patients do not have these antibodies.
Okay.
So it's not. It's a supportive criterion if you have these, so that makes life easier. But it's not because the patient does not have these antibodies that it's not MMN. And why this is the case is difficult to say. Is it a technical problem that you can't find these antibodies? Methodology in the lab. So it's not easy.
Okay. Yeah, I mean, like all other antibody-mediated disorders, you may not always detect the antibodies.
Yes, indeed. It's the case also with GBS. Some patients do have antibodies against gangliosides. And of course, others may never have these antibodies, a special subtype of GBS, of course, linked to the axonal variant. But yeah.
Great. Thank you very much. There is one more question. Is there an electrophysiological distinction between treatment-related fluctuations in GBS and acute onset CIDP? For example, can the involvement of a previously unaffected nerve be considered a criterion for acute CIDP?
I'm not sure I understand the question because
I think the way I understand it.
Yeah, no, you have the treatment-related fluctuations, which is quite typical for GBS, and in 5 to 10% of the cases this happens. And it's thought to be due to the fact that if you treat with IVIG, that you get a good improvement to start with, but as the level of IVIG decreases in the bloodstream of the patient, then he relapses.
Yes.
And this is called a treatment-related fluctuation. If you treat the patients again with IVIG, then it will improve again. And this is not really what you see typically in acute onset CIDP. So that's true only for Guillain-Barré syndrome.
And is it possible to see a nerve that, being abnormal on the nerve conduction in the follow-up study that was not abnormal in the initial study in GBS patients?
I'm not sure, but if it's really acute onset CIDP, yes, then it may worsen.
Okay. So it's less likely to happen in a typical GBS patient that you have progression to nerves that were not initially affected.
Right. I think that's true.
Okay. Okay. I would just note here that sometimes, GPS weak conduction studies may be done too early and you don't see the full extent of the pathology if it's done within the first week. So sometimes we do see in the second week more electrodiagnostic abnormalities. I don't know if you agree with that.
I fully agree with this, yes.
So,
That's typical of Guillain-Barré syndrome. So it really is an evolving story. So the abnormalities you find or do not find at the beginning may come after a week, after several weeks. So indeed, there is a progression and evolution of different kinds of findings. So that's certainly the case. So it's not because the nerve conduction studies are normal when the patient comes in the hospital, you do the test, then it will be normal a week after. So if it's really a diagnosis of Guillain-Barré syndrome clinically, then indeed I usually repeat the examination, the nerve conduction studies after a week or after 2 weeks, and then you see after that you get more information that confirm the diagnosis. But then again, GBS is a clinical syndrome, and you do not really need positive nerve conduction studies to start treating the patient.
great. Okay. I think we don't have any more questions. Thank you again, Professor van der Bergh. This was a great webinar, very informative and good review of the whole topic, which is really crucial. Thank you, everybody, for joining. Just a reminder that we have another webinar next Thursday. It's about nerve imaging, same time, ultrasound use in peripheral nerve disorders, and nerve imaging using MR neurography. We will have 2 speakers, Nens van Alphen and Stefan Goedi. So please join us also next Thursday. And I would also like to remind the neuropathy community about the quality of life survey that was distributed by the EURO-NMD office. Elizabeth just shows the slide about this, so please respond to the survey. It would be very useful for collecting the information about this important topic in patients with inflammatory and dysimmune neuropathies. Thank you very much for joining and for your attention. Thank you again, Peter, and have a nice rest of the evening.
Thank you. Same to you all.
Thank you, Peter.
Bye-bye.
Bye-bye. Thank you, Cleopas.
Thank you. Bye.
Bye-bye.